So what is going on over here? Could this be iatrogenic? That's always the first thing which comes to our mind because we've done a surgery for him. We couldn't quite remember if the surgery had involved the medial rectus. If it did, then most likely the adduction deficit is probably from a slip muscle, loose pole, maybe a stretch scar. And if it's not iatrogenic, then we are a bit more worried. So let's now, finally, we got the notes. We noted that we had done a bilateral lateral rectus recession of 8 with bilateral inferior obliques, and the medial rectus was untouched. In a way, you breathe a sigh of relief, but then again, you're worried because now what is going on? Could this be iatrogenic? No, this is not iatrogenic now because the medial rectus wasn't even touched. So let's now re-look at the video again. So once again, take a look now and see what is happening to that adduction in the right eye. There's an adduction lag, and there was an abducting nystagmus. Would you like to see the video again? So right eye adduction lag with a left eye abducting nystagmus. Okay, so now already majority of you in the audience have begun to know that is this concomitance worrisome? Of course, it's an immediate red flag. Okay, we had to send for a neuro-ophthalmology consult. They did extensive tests, which included imaging. And the MRI showed that there were these hyperintense lesions along the periventricular white matter. And we saw the classical Dawson fingers, which are signs of periventricular demyelinating plaques along the axis of the medullary veins and perpendicular to the border of the lateral ventricle or the callosum. And this is classical, as you know, of a demyelinating condition or a multiple sclerosis. It's a bit atypical. We don't see multiple sclerosis as often as in the West. In Asia, and the gentleman was only 30 plus years old, so rather atypical. Lessons learned is please pay attention to the motility pattern, especially to adduction deficits, which can be very easily missed in our busy clinics on a quick cursory examination. Next case now is a 36-year-old gentleman who comes to us with horizontal and vertical diplopia. And here, true enough, he has a esotropia, he has a hypertropia. He seems to be proptosed bilaterally, but then in Asia, there's myopia. Singapore is the myopia capital of the world, okay? And we also have a lot of thyroid going around, okay? So ESO, hypo, and here he is on lateral gazes, and here he's on up gaze, so there's some limitation of abduction, there's limitation of elevation. So here we are going to share the video with you, and I've used a Spielman purposely just to let you see what's going on undercover. There's a hypo, there's a ESO, okay, and then we go on to his eye movements. Some abduction deficit there. A little bit more on the left. And let's see what's happening on up gaze. I'm trying to ask him to look up. And there's a hesitation to up gaze. So the next thing we would like to do here is we used an optokinetic drum to try to simulate and stimulate an upward saccade. And here you can see there's an optokinetic drum which is rotating vertically in front of him. And all of you can see what's going on over here. There's a bobbing. Would you like to see that video again? Yes, okay, so. This is in response to an optokinetic drum trying to elicit upward saccades. Okay, so you can see that the eyes are converging, and there's a convergence kind of a nystagmoid movement. So what next would you like to do? Any guess from the audience? We want to check the pupils. Okay, and I'll show you a video of the pupillary eye exam. So we are just checking the pupillary light reaction. This is for light, which is for distance, of course. You can see the pupils look a bit dilated and do not want to react. And now we are showing him a near target, and we are asking him to read. And there you can see that the constriction. So in addition, there was a reduced convergence. You have your big red flag waving around over there, and true enough, this was a Perinaud's dorsal midbrain syndrome, okay, and he went in for surgery, he was shunted, and the histology turned out to be a pineal gland germinoma. So in summary, red flags are fellow travelers. Keep a lookout for them. Look out for concomitants, adduction deficits, look at the lids for retraction, ptosis, changes in the fissure. And last but not the least, please remember to do pupils in all our strabismus patients, look for accommodation deficits and light near dissociations. Thank you so much.